Hello and welcome to MedCity's Pivot Podcast. I'm your host, Arundhati Parmar, Editor-in-Chief of MedCity News. This month, we're talking about interoperability and how we get from interoperability to value-based care. Our guest today is Particle Health CEO, Jason Prestinario. Now, Particle Health is a company that has created a single API through which payers and providers and digital health companies can basically connect to health information networks and access medical records data that will help patients. It's a very interesting company, not the least of the reason being they have a lawsuit against Epic. We're in the middle of that lawsuit right now. So when I thought of having a discussion on the state of interoperability today, I thought we should definitely have a conversation with Jason. Hi, Jason. Welcome to the MedCity Pivot Podcast.
Thank you so much. Thank you for having me.
So CMS has made some strides when it comes to interoperability under different administrations, the Trump administration included. How far do you think we've come in terms of interoperability, healthcare interoperability, and what letter grade would you give, CMS and other agencies in sort of furthering the cause of interoperability in the U.S.?
Yeah. So first off, just to take a moment to say, excited to be here, CEO of Particle Health. Particle Health is a data intelligence hub covering more than 70,000 healthcare organizations nationwide. See over 50 patient-provider interactions per second, process billions of data points across longitudinal medical records. And unlike basic data exchanges that simply move information from point A to point B, Particle is built to transform those fragmented records into actionable clinical insights that power better patient care. So obviously, with that as what Particle is and what we do, we certainly spend a lot of time thinking about and caring about interoperability across the country. I think what I would say first and foremost, which is maybe a little bit tongue-in-cheek, but I think it actually speaks to the point is, I would actually love to not spend any time talking about interoperability and sort of where it stands today, right? My hope would be all of why this data is valuable to use for patient care, advancements in how we're able to use it to better understand next steps for patients, and talking about the level of impact that it's having on the quality of care. That's what I would love to spend time talking about. But obviously, none of that really matters if the data isn't actually accessible to begin with. So all that's to say, I think where things currently stand and, to give it a letter grade, I think that's hard because it's all about, I'd say the derivative is positive, right? We are trending in the right direction. I think a lot of kind of recent advancements and pushes have been made, which is obviously pushing us towards more interoperability. The health tech ecosystem that CMS launched last summer, which we were one of the original signatories of, has really put a lot of emphasis on and a lot of spotlight on the need for medical records to be made more accessible. And so, whenever we are trending in the right direction, to a certain extent, that's what you have to ask for, right? So I think positive marks all around in terms of the better advancement and being better today than we were yesterday and better tomorrow than we are today.
So you can't give it a letter grade because the progress hasn't been that great, or why not? It's complicated to simplify it like that.
Yeah, I think partly is it's too complicated to simplify it like that. I'll put it this way, first and foremost, maybe. When it comes to the actual pipes, if you will, we're at a B, I'd say B plus. We have come pretty far in terms of that data being able to be transmitted digitally without a whole lot of overhead. There's still, institutions out there and providers out there that are not connected. There are still some. But by and large, right, as I mentioned, we see, again, 50 times a second, we are seeing transmissions and interactions going back and forth where providers are seeing patients and requesting medical records and, and pulling that through. So in terms of the pipes themselves, yeah, I mean, I think that's at a B. We're in a pretty good place. I think where things start to get more complicated is who gets to use the pipes and when and under what purpose and for what and for why and so on and so forth. And that's where I'd say we're still, at a C maybe at best in terms of kind of our current state of the world.
So we'll talk to who gets to use it and how further down in our conversation. But let's talk a little bit about what are the gaps that need to be filled. You said you wanted to be in a place where you're not talking about healthcare interoperability anymore. How do we get there?
Yeah, I mean, I think first and foremost, right, we need to see, all of the legal framework, all of the kind of agreements, if you will, the regulations, the laws that have been made, all are pushing us in the right direction. I'm actually, interestingly enough, I realize I'm coming up on my 10-year anniversary of being in healthcare, which also, ironically enough, is about a 10-year anniversary of the Cures Act, being signed into law in 2016. And, that was really the starting point of really saying, no, we want to ensure that medical records are made programmatically available. And, obviously, as the years passed, we got closer to the final rule and, putting both the carrots and the sticks in place. And, I'd say largely they are at this point. There are information blocking penalties and statutes that are in place to ensure that, and like I said, all purposes of use are responded to, and individuals can get access to their medical records, their doctors can get access to their medical records. So I think the infrastructure in many ways is in place. I think what still remains, as a gap is, again, getting just alignment on following all those rules, understanding who is going to be the adjudicator of those rules, who is going to oversee the process. We kind of have an alignment on the rules of the road. We kind of have, I kind of view it as we have the speed limits in place and things of that nature, and but also the roads that we need. And now the question is, well, what happens next? How do we really start to say, let's turn it on and, let's see what happens and make sure that we are, kind of pulling back when and where we need to pull back, but ultimately overall focusing on, we want the flow of information. We want the democratization of this data and the use of it, right, in order to improve patient care.
So I wanted to ask about the latter part, improving patient care. We've been talking about value-based care for a really long time. And I kind of feel that interoperability is sort of the underpinnings of value-based care. If you cannot get data from different sectors and different parts of whatever you do, how do you, if you can't improve what you can measure, right? So do you see those two as sort of married to each other? How closely do you think interoperability is viewed as really important to value-based care?
Yeah, I mean, first and foremost, I think, the concept of value-based care is in some ways continuing to evolve and change, but in other ways has been around for, a very long time, right? The idea of, a Kaiser, for 50 years now, right, being sort of on the one hand, a plan that is focused on the care of its patients and members, but on the other hand, obviously being, a provider of their own right and sort of being that payvider that's kind of thinking about both sides, right? That's not a new concept. But obviously there have been, a lot of advancements in, and again, right, credit to, if you will, the largest payer in the country in CMS, for largely being the ones to spearhead these kind of new novel programs, right? So their latest access program is, another opportunity and experiment in some ways, right, to see how we can continue to open up new ways to say we care about the actual end result of how healthy is this patient. How we get there kind of doesn't matter, right? Which obviously is kind of a direct antithesis of a more fee-for-service based system, which really just says, let's count up all the procedures that were performed. So that is to say that I think value-based care has been around for a long time. We are seeing more and more opportunities for it to be used and to be pushed throughout the ecosystem. I think it's hard for anyone to argue that the theoretical benefits of value-based care are very real. And then obviously there's a question then of, pragmatically, are we able to achieve it? But we're striving, right? And I certainly think that is a good thing and a good place to be in. And to your point, interoperability and data flows are certainly, and really more than, like I said, just the flow of data, but it's the understanding of that data become really critical towards doing value-based care well, right? Ultimately, a lot of the ways that we think about it is it's still certainly important for, even a fee-for-service provider to care about the patient that's right in front of them, right? I mean, I think if you were to ask pretty much any doctor out there, would you rather know more about your patient than less? I think they would say, yeah, I'd love to know more, especially if, it is what I need to know when I need to know it and, not 1,000 pages of medical records that I don't have time to read. But I think pretty much every doctor would say, yeah, I'd love to know more about the patient that's in front of me. I think the difference with value-based care, though, and what that means for how CMS and other payers are continuing to kind of push that ability to really sort of think about the care of those patients and those members is now I care about what happens outside my four walls, right? I care about what's happening when this patient's not directly in front of me, and I care about the outcomes, right? The value, if you will, side of it. Of that patient. And that fundamentally is just a different paradigm, right? That is a paradigm that requires information and data from elsewhere because by definition, they're not right in front of you. And so to me, it's the difference between, even in a fee-for-service model, it's a nice to have, right? No provider out there, I think, is going to say, no, don't tell me about my patient. But if, in a value-based care construct, it becomes a requirement. It's a need to have. And that to me is the difference as I think about how interoperability is great for everyone. It is a need for value-based care.
So let me talk to you about interoperability networks. We have a bunch of different ones, right? We have TEFCA, we have Carequality, we have Commonwealth, we have eHealth, if I'm not mistaken. And what's the purpose of having so many? Wouldn't it be better for data fluidity and just better data flow or easier data flow if there were just one or two?
Yeah, this is an interesting observation you have that I certainly have spent time thinking about, because I've talked to people out there that have said, I think there should be, there should always be multiple sort of networks and there should never just be one network. And I'll be honest, I don't really track that. I don't really understand that, right? I think the way that if I'm a patient, if I'm a doctor, the way we certainly think about it to, service, the healthcare ecosystem here at Particle, I don't care where the data comes from, right? Like I'm not thinking and tracking about, oh, well, this piece of information came from Carequality, this came from Commonwealth, this came from TEFCA. What I care about is, do I have as much, frankly, hopefully all, right, of the data on this patient in order to make my decisions? I don't really care where it came from.
Right.
So that's kind of where the push on, oh, we should have multiple networks and things of that nature, I think is a little, I don't really understand it. I think that, while there are certainly different networks out there and they all are kind of starting to have different, areas where they're strong, right? So obviously, TEFCA now and QHINs are becoming one of the, most important parts for individual access, which is now kind of really, the reason that you would connect to TEFCA. Obviously, the CMS ecosystem and aligned networks are also trying to really push into that and, kind of be the leader versus the floor and the way that they frame that across ONC and CMS. But the reality is that the majority of, information exchange that's happening across, between healthcare, organizations today is still Carequality. That is still by far the largest source of information out there. TEFCA, in their history is sort of celebrating doing 100, 200 million requests. Carequality does more than 1 billion every single month.
Right.
So it's just literally an order of magnitude difference
Yeah.
between the
Yeah.
two. So, to me, it's like, should we continue to have all these different networks? Theoretically, as a interoperability company, right? Theoretically, it's like, oh, that's great. That's more barriers to entry for us, if you will, because there's all these different networks that you have to connect to. But we don't really think that way. To us, the more democratization of data, the better. The more access to data, the better. What the questions then, the much more valuable questions to answer is, once I have the data, what am I going to do with it in order to really understand it?
Sure, that makes sense. Okay, so you can't talk about interoperability without talking about lawsuits. You're party to one of them. So let's start with that. Let's start with your lawsuit against Epic. Now, you sued in 2024 because you allege that Epic is using its market dominance to prevent competition in the payer platform space. Obviously, all of this began when Epic sort of started blocking some of your customers from accessing patient data. And Epic is basically saying that, well, these customers were accessing the data not to treat patients, but actually to make money off of selling off the data. Now, I know last year a federal judge ruled that the core argument that you had of antitrust, that can move forward against Epic. So I guess the question is, A, first of all, did I describe all that very clearly and correctly? And B, why is this case important to the industry?
Yeah. I mean, the way that I've always described it, right, is that this, lawsuit and why we're doing this is about making data work for patients, right? That the only way we can get to, again, that healthcare system that delivers better outcomes based on, understanding the patients and understanding what's happening both to the patients that are right in front of them, but also patients that are outside those four walls. Is for that, data to flow freely, right? For it to be accessible. And obviously we haven't even spent that much time talking about, AI and how it's going to transform healthcare just like every other industry. But, one of the things that we find very interesting is the use of AI in our industry largely doesn't touch clinical outcomes yet. And the reason is not, and there's more and more kind of research being done that, like everywhere else, AI is improving leaps and bounds. And I don't think anyone's saying that, AI can't be a help in understanding clinical outcomes. I don't think that's a particularly tough leap to make, but it requires data, right? It requires to actually understand what's happening with the patient and allowing it to be, accessed. And as I mentioned, right, the 10-year anniversary of the Cures Act, this isn't a controversial view, right? This is what's in all of our laws. So we did see, right, that there was blocking of information that was occurring, and that was impacting, patient care. That was impacting people who were trying to deliver outcomes for patients. And we believe that obviously Epic is using that monopolistic position to stop the flow of healthcare data. And that's bad, right? For all the reasons we just talked about. That's bad for individuals. That's bad for the patients. That's bad for the professionals. And it is not it runs counter to the laws that were put in place, in order to ensure that patients had access to the best care, that the best care models were able to be innovated on, that could lead to more choice in healthcare and more opportunity for patients to get better outcomes. So frankly, that's the reason that we felt it was an important move for us to make. And so I think that was your kind of first question on kind of why we did it. In terms of the current status, that's right. So in September, as you mentioned, right, the judge ruled that we were going to move forward on the kind of core antitrust complaints. That was the first time in Epic's history that an antitrust case has gotten to that point. And since then, we've been undergoing, a lot of kind of discovery in sort of this initial phase. There's a lot of kind of even in the last couple weeks, a lot of back and forth around that sort of first initial discovery phase. We're excited to continue kind of marching forward. Kind of all the procedural legal back and forth, can sometimes, frankly, be a little bit beyond me. But the important point being that we are continuing to advance forward, continuing to march forward with this, with this lawsuit in this case. And we're continuing to look forward to, we think our claims are strong. We think our position is strong, and we continue to look forward to, marching the ball forward.
I'm curious about what you think about Texas's lawsuit against Epic, because they too have sued on the basis of that it's trying to stifle competition.
Yeah, I mean, we're seeing at this point, several different actors, right? So Curious was another company who sued under antitrust not long after we did. You mentioned Texas. There was also a not antitrust, but an employment complaint that Veeva actually brought forth as well. I think that there's just a recognition that at a certain point, the Davids of the world have to stand up to Goliath and have to, sort of say, hey, we can do the right thing here, and we can, stand up for that. And not to say that the state of Texas is David by any means, but it is to say, right, that I think there's an understanding here that. That there are activities, there are ways in which Epic operates that I think people are starting to recognize need to be questioned, and that's, I think, what we're seeing across the industry.
So I'm not going to comment on the merits of any case because A, I'm not a lawyer, and B, I don't know enough to comment. But I do, I can talk about the recent developments. They too have sued. They've sued Health Gorilla, alleging again and the same thing, that the patient data is being accessed for selling to lawyers for non-treatment purposes, right? They're saying these entities, Health Gorilla and a few other companies, are basically using this to enrich themselves in the name of treating patients. And I'm forgetting the name of the company just now, but there's a company in March that actually settled with Epic, right? Saying that, okay, they sort of admitted to some of the allegations, I guess. And I thought, well, that boosts Epic's case. So Epic is also not wrong when it alleges that people and entities are misusing the data. Would you at least give them that?
Yeah. So, I mean, first off, the disclaimer, of course, that I also am not a lawyer, and I certainly, I'm not going to overly comment on sort of the merits of any specific case, of which other than ours, of course, of which I am just a backseat observer, just like everyone else, obviously. But, what I will say is, I think, first and foremost, that anytime there's any, kind of speed bump, it's kind of in these networks and in this data access, that can't be used as an opportunity to set back information sharing, right, for years. So first and foremost, I think that's an important thing to recognize is. There will be speed bumps along the way, and we need to look at those speed bumps, and we need to carefully analyze them, and we need to investigate them. And we believe very strongly in that. We've really, I think bar none, we have the strongest compliance program out there, and we thoroughly investigate and look into, what's happening, not just with ourselves, but frankly, throughout what we can see right in our 50 times a second that we're seeing patient-provider interactions, because it is really important, right? You have to respect that this is important data, that privacy and security, are relevant things within, the HIPAA construct and the sanctity of PHI. But, we also can't suddenly say that, that flow of information needs to be stopped, right, every time that there's a speed bump along the way. So that's kind of my overall kind of first point. I think my second point, though, very specific to, again, the allegations I see having no more information than anyone else is, there's a very interesting question here, right? Epic's alleging that, to your point, this was information being taken and sold to law firms effectively without the patient's authorization.
Right.
That's very different, right, from a patient authorizing the access of their data and requesting and wanting their data to be used for whatever purpose. And obviously then that data being requested under a treatment purpose of use. Now, I want to be very clear, right? If it's not a treatment purpose of use, you shouldn't request it under a treatment purpose of use. But I think there is a massive difference here, right, between an individual patient saying, I want this, right? I want my information to be used. And a law firm taking information from patients who haven't authorized it and trying to monetize it. And to me, we don't know, right, what's actually under the hood here. We don't know which one is true, because if it's the former, right, then again, should not have been requested under a treatment purpose of use. But that is what all of the CMS health tech ecosystem and aligned networks, that's what they're all about, right? That we should give patients access to their own data. And if it's the latter, then that's a totally different ballgame. And I think what's interesting and over time, maybe we'll see is, if it's the latter, there should be HIPAA violations that are coming at this, right? OCR should be saying, actually, there are a bunch of, HIPAA breaches that have occurred here. And again, we don't know, right? Those investigations take a while. Maybe they're happening under the hood. But I point that out because I think I don't think enough people are talking about what are these two very different modalities of what might have occurred and transgressed.
Yeah. I mean, from what I've seen reported in our own publication, one of our reporters wrote a story. They were creating shell websites and creating fake provider IDs, and all of that obviously sounds pretty horrible.
Sounds terrible.
Yeah, but are you saying that if a patient decides to share that information, share their medical data with any other entity, and it doesn't have to be for treatment purposes, that facility exists today for the patient to be able to share that information through Epic or through any organization, or no?
No, that's the problem, right? That's the problem. That's the core issue that we need to solve. That's the core interoperability. That's why we still have that C, right, as the mark to bring it full circle, is that facility doesn't actually work today. It doesn't.
Because no matter what, I'm sorry to interrupt, but no matter what people say, I've heard people and physicians say, data belongs to the patient, but actually, I don't think data truly belongs to the patient. It belongs to the hospital and the EHR companies. I never get the sense that I can easily access my information if I want to. Yes, now it's gotten better with patient portals and things like that. But, it's still a lot of paperwork to fill out and call and request and this and that. Even to get a copy of your MRI is such a huge issue. So, how does that change? How does that framework change? Because Epic's making money off of that data too, right? And so are the providers and so on. So is everyone except the patient.
Yeah. Again, the way it needs to change is we just need to continue enforcing the rules that exist today, right? We need to see information blocking complaints turn into violations, turn into penalties. I think, again, just like speed limits and tickets, right? It doesn't mean that we need to file information, complaints and have penalties against every information blocking transgression in order to change behavior. As soon as people start to believe that the penalties associated with information blocking are real, then they think they will start to pay attention to them. But as it stands today, They're kind of not.
Yes.
There's really nothing that prevents it. We filed our own information blocking complaints against Epic as well, based on some of the activity and the information blocking that they had, performed actually against themselves, right,
Mhm.
where they blocked their own providers from being able to access data from some of our customers, things like, community oncology centers. I'm hopeful that someday, we will hear back on some of those complaints. But I think that's what needs to happen, because you're right. That is true that today, and actually I can tell you this because we've looked at the numbers. I mentioned the majority of transactions are occurring on Carequality today. There's about 120,000 kind of active sites where you can pull data from kind of Carequality and otherwise from these legacy networks. TEFCA has, I believe, 60,000. So it's about half, first and
Mhm.
foremost. And then within that, only about 15,000 of those sites, you can actually pull individual access information based just on an API
Mhm.
call. Everything else requires, well, you still have to do your login and authentication, login and password for your MyChart instance of Epic in order and state, here's who I want to give access to, for how long, what pieces of information. You have to do that again and again and again for each and every login. If you remember your login, if you remember your password. And that's just really onerous, right? Like that's not easy programmatic access to your own data. And so that's what's still blocking things. And I can tell you just even from my own experience, recently there was information pulled on me, through interoperability networks for a treatment purpose of use. And I thought it was really interesting because there was actually some records going back to when I was in San Francisco over a decade ago. I was like, oh man, these records still exist at Sutter Health, and these records were pulled on me. And then I was curious. I actually checked. I don't have a Sutter Health MyChart login. I have no login or password. So to your point, literally, there's no way for me to pull those under an individual access paradigm because I don't have a MyChart login. Now I could create one, and to your point, that was gonna, give Epic more money because now Sutter's gonna have one more patient on a MyChart login and all of those things. And that data should be accessible regardless, right? It shouldn't require that type of login and password in order to give me access to it.
Okay, and finally, to close, are there any particular regulations or CMS actions that you're looking forward to that might be coming down the pike regarding interoperability that might make things a little bit better even down the road?
Yeah, I mean, listen, I'm, still actively involved. Myself and some of the folks on my team are leading some of the work groups within the CMS ecosystem. July 4th, there's kind of another tranche of deadlines
Mhm.
that people are marching forward towards. I'm excited about all of that. I think that um, we need to continue to emphasize all of the aspects of data access, accessibility in the ecosystem. We need to ensure that that data is working for patients through providers and payers and value-based care organizations and payviders, and not just focus on individuals accessing their data. But that's still part of it, right? Any and all progress forward on making sure that data is accessible by patients and their caregivers and everyone in the ecosystem who needs access to it. I'm here for all of it.
Well, on that hopeful note, thank you so much for joining us at MedCity Pivot Podcast today.
Absolutely. It was a pleasure.